I'm now going to invite myself to give a talk on something which should have been given by a scientist, a basic scientist, a physiologist, an epidemiologist, but I will probably have to fill in the shoes for the gentleman or the lady. I will try to do justice to this difficult topic. What I have done is I have collected the literature on weight regain after bariatric surgery, both from basic research and the bariatric surgery cohorts, and then try to see clinically how does this help us. It appears to be a very, very dry and boring topic. The more you delve into it, the more you realize that we're just scratching the surface. So let me tell you and begin with telling you that a century back, this eminent psychologist said, most obese persons will stay in treatment. Of those who stay in treatment, most will not lose weight. Of those who lose, most will regain it. So weight regain has been the stumbling block known to psychologists and nutritionists for a century. But the bariatric surgeons are probably just getting more aware about it because we've started in the last 3 decades when laparoscopic bariatric surgery became popular. So it was no surprise when Dr. Alison Filders made this paper, published this paper in 2015, showing that patients, obese patients who wanted to lose weight with diet and activity over a 9-year follow-up period, they had intention to lose, and with diet and activity, the results of diet activity producing weight loss was dismal. Just look at one line. In morbidly obese person, the chances of that person reaching the ideal body weight range is 1 in 1,000. That's like saying there is no chance. And the stumbling block here is, again, weight regain. Not that they don't lose weight initially. It's just that they recover, they regain a lot of weight. So what is the science behind all this weight loss and weight regain, if I may ask? And to understand this, when I read the literature, I thought the best way to explain it to clinicians present in this room is by first talking about why there is weight loss after dieting, then why there is weight regain after dieting, then talk about weight loss after bariatrics, and that will easily explain what causes weight regain after bariatric surgery. But first, there are certain acronyms and graphs I need to just quickly go through to make it easy for the later talk. This is an oversimplification which everybody is aware of, and it's probably not exactly representative of how weight is maintained by the body. This is an important graph where it shows that 70% of our energy expenditure is on basal physiological functions such as circulation, posture, breathing, and that is where we spend most of our energy without a realization. 10% of our energy is spent on digesting food that we eat, that is TEF, also known as DIT, and TEA or PAL is the energy spent on physical activity. Now see how low a proportion this is compared to the total energy expenditure. So when you want to change somebody's energy expenditure by physical activity, it's such a small subset to change. And if you wanted to change really, it should be the basal metabolic rate or the resting energy expenditure. DIT and TEF are the same. This is important because when we say this, when we read the literature, this will come up very often. Resting energy expenditure and basal metabolic rate or resting metabolic rate are not synonymous when it comes to reading the literature. Resting energy expenditure is the total amount of energy that you are spending on basal functions, whereas basal metabolic rate or RMR is per kg body weight. So when you're talking about per kg body weight, that's a different thing altogether, as you will see in further slides. Also, BMR per kg fat-free mass is also different. So when we talk about basal energy expenditure and we talk about 3 ways of expressing it, I wish Kamal was here, he would have understood that I was going through the literature, and the way you define it actually actually makes a lot of difference into the conclusion of a paper. So, if you look at resting energy expenditure, it is positively associated with fat-free mass, which means if you're more muscular, you have more resting energy expenditure, you have more basal metabolic rate. Okay? And I've already said that resting energy expenditure and weight-adjusted resting energy expenditure are different. The second one is the resting metabolic rate or basal metabolic rate. How is this BMR and fat-free mass measured? Well, in experiments, they are either measured with calorimetry, which is direct or indirect, direct being more accurate for measuring the basal metabolic rate. And the fat-free mass is measured with DEXA scans. And this is what the papers are going to tell us. So, how does weight loss happen after dieting? Most of us are aware that if you cut down 500 calories in your diet per day, which is about 3,500 calories in a week, you should be losing about half a kilo in a week, which means 2 kilos in a month. So, technically speaking, a 50-kilo man should disappear in 2 years' time. But that doesn't happen. And it doesn't happen because weight regain is your stumbling block. It prevents from something like this happening, okay? And why that happens is because your resting energy expenditure shrinks when you eat less, which means your energy expenditure goes down. So, the lower you're eating, the lower your energy expenditure, so weight regain is going to prevent you from losing more weight. That is called metabolic adaptation. However, I would like to draw your attention to one study on metabolic adaptation to understand this further. There are plenty of them. The one which I like to say is the one where Dr. Johansson and Dr. Hall studied the Biggest Loser competition subjects. As you know, in the United States, they have this Biggest Loser competition where it is televised. Obese subjects are put into a 3-month diet activity gruel, out of which they come out leaner, and there have been people who've studied them. And what they studied is, with the diet and exercise, when they lose weight, 84% is from fat and 16% is from fat-free mass, as opposed to bariatric surgery patients who lose 70% from fat and 30% from fat-free mass. And when you see 16% fat-free mass, and as we know that resting energy expenditure is proportionate to the fat-free mass, you would expect that with the 16% fat-free mass reduction, you should have 280 calories per day energy shrinkage. However, when you measure through calorimetry, what do you get? You find that the shrinkage is almost 800 calories. So where did the 500 calories go? How did that shrink? And that is metabolic adaptation. And probably that sets what the scientists now hypothesize as the cause of obesity and weight regain. They try to use one of the hypotheses, which is called the set point hypothesis, that there's probably a higher cerebral function which resets the energy expenditure. So we have understood about the weight loss and regain to a certain extent after caloric restriction. What about weight loss after bariatric surgery before we enter into weight regain after bariatrics? Well, it seems that yes, there's a dramatic caloric restriction which will account for the weight loss, but it does not account for all the weight loss. From all the experiments that you do, you find that the weight loss is far more than that is explained by the caloric restriction. So where is that coming from? One, of course, there is less decreased absorption if you're bypassing, and that could contribute. And there are certain hypotheses or postulates, I would say. Nothing is black and white in this field, but what is there is, people talk about a metabolic rate going higher. I will explain that. It's a very double-edged sword, that statement. Hormonal changes, both at the level of the gut and adipose tissue, alteration of the gut flora, changes in the bile acid metabolism, and alteration of stress response. And all this is responsible for weight loss. Let's see what that means. Hypermetabolism. Here I would like you to pay attention. I know it's a tall call, but that's what I would like you to do. When you look at the different papers presenting, you might find papers saying resting energy expenditure decreases, Sometimes you'll find metabolic rate increases as a conclusion, and somewhere you will find metabolic rate decreases. What sense does it make to you as a bariatric surgeon? Well, if you look at all the papers, majority would agree that the weight adjusted resting energy expenditure is increasing, although the total resting energy expenditure is either equal or lower. Now, it will take you some time to absorb it and throw back a question to me, but I'll leave you with that, just with that explanation, that if you see this after bariatric surgery, you are losing 30% from fat-free mass. It is inevitable that you're going to lose your resting energy expenditure. It's going to shrink. And if you compare it with caloric restriction, that's dieting, you would expect some metabolic adaptation. Probably that is not taking place as much as caloric restriction, and therefore you get weight-adjusted resting energy expenditure as a higher value. But these are my surmises, and I'm sure you would have your own, and we can all discuss that later on. When it comes to hormones, we know this. At the gut level, we find that the GLP-1 levels have gone up, ghrelin has gone down, leptins have fallen down. Now, how much of this is the cause of weight loss? How much of this is the effect of weight loss? We do not probably know, but we do attribute that these are the peripheral signals to the higher cerebral function to cause more weight loss. Gut flora. Now, what has gut flora to do with weight loss? Well, it seems through biogenomics that there is a lot of what gut flora has to do with weight loss. And not only with weight loss, but with immunity and different diverse aspects of health. If you just look at the changes that body weight loss brings about in gut flora, this is tremendous. It's overall increase, firmicutes are increasing, Clostridia cluster is increasing, archaea is increasing, certain bacteria going down. Well, we are not here to read the species name, but what we understand is there's a lot of changes in the gut flora with weight loss. Bile acid metabolism. Yes, the bile acid receptors are important. They're important for how we absorb and assimilate and store nutrients. We know that. And we thought it was only important for bypass. Recent paper suggested that the sleeve gastrectomy works not only through the suppression of ghrelin, but probably more importantly, through alteration of bile acid receptors. Now, that's food for thought. That's how important this particular slide may be. What about stress response? Well, when you restrict calories, what happens? You go under some sort of a stress. There's an activation of hypothalamic pituitary adrenal axis, and that causes weight gain. It counteracts your effort to lose weight. Whereas when you do bariatric surgery, somehow the hypothalamic pituitary adrenal axis is obtunded, and therefore that might contribute to why we lose weight with bariatric surgery. So these are the various methods that bariatric surgery may be causing so much of weight loss that is not explained by caloric restriction. So coming to the crux of the matter, then why is there a weight regain when all these biological, physiological processes are working in tandem towards weight loss after bariatrics? Why is there a weight regain? Well, it seems it's multifactorial, which is the best way of saying that we don't know so much about a particular thing. So first thing is, well, it could be a bad surgery, as has been mentioned before. There could be anatomical reasons, and not necessarily a bad surgery. We are operating on a flexible organ, a dilatable organ, and that dilatation can happen in the form of the pouch, the stoma, the sleeve tube, anything. And therefore, anatomical reasons could be one, physiological reasons, and behavioral reasons. These are the three reasons why we can have weight regain. Anatomical reason. If you look at the literature of the sleeve gastrectomy dilatation and you try to see up with weight regain, it is probably true that the correlation is not invariable. You may have weight regain in people who have normal sleeve pouch, and you may have a sleeve dilatation without any weight regain. Similarly, in Roux-en-Y gastric bypass, although most of us agree that the stoma diameters probably can dictate about the weight regain, there is literature suggesting that non-regainers can have the same kind of barium studies as the regainers. A little bit of a difference here and there, but nothing much. So we don't know. Eating behavior and psychological profile obviously has a bearing, and there are plenty of papers suggesting if there's anxiety, depression, and disordered eating, that can lead to weight regain, and that's absolutely common sense. There's no rocket science there. But let's go to the point that I was going to make. And I just set up the stage to say this for the last 15 minutes, just to tell you this, that there are plenty of physiological reasons for weight regain. The same reasons which are responsible for weight loss after bariatrics are probably not durable effects. The hypermetabolism that we talked about, Dr. Cardile did this study where he looked at the metabolic rate, both basal as well as digestive-induced thermogenesis, which is energy spent on basal function and energy spent on digestion after bariatric surgery in regainers versus non-regainers. And what did he see? He saw that the basal metabolic rate was higher in the non-regainers than the regainers. He saw that the diet-induced thermogenesis was higher in the non-regainers versus the regainers. So hypermetabolism is going down in the regainers. Hormones, the same hormones that we saw, the GLP-1 rising, GIP responses, they are going in the opposite direction in the regainers. The leptins are again going higher. What about the gut microbes? They're seeing the reversal of the gut microbes to the pre-operative level. Genes, now, there are 370 genes that has been identified already which can alter absorption, storage, and not only that, even our behavior. What food attracts us? What do we want to eat? Do we want to hit the gym? Do we want to play cricket? Or do we want to hang on with our phone taking calls for our profession? All that is genetic. That was a dig at my friend, he is not here. So, genetic loading may be the important factor which tells us who you're going to be in terms of weight regain and weight loss. It's just scratching the surface now. Cellular inflammation. Well, what has cellular inflammation got to do with obesity? It seems that obesity is an inflammatory disease. And it seems that we do not know whether it's a cause or an effect, but we can use this information to predict weight regain. I've told you so much of dry stuff. Most of you probably would be wanting some coffee now. Yes. So what I'm going to give you is why all that was important to the surgeons. The first clinical application, direct message. Because of so many factors that can be responsible for weight regain, we need to assess weight regain. We need to know how to assess weight regain. We need to know how to measure the physiological processes that we have talked about. We don't even have any parameter to check on the genes. I've checked with the geneticist in Hyderabad and we worked out for last 6 weeks what to do. We don't know. We don't know how to measure GLPs in an easy way. We do not know how to check on metabolism, but we do know that we can see anatomical changes in barium, and it's simple. It's a few hundred rupees, and we can do revision bariatric surgery based on that data. Does it strike you, gentlemen and ladies, as a good idea as a scientist? I'm just setting a stage for Raman Goel versus Mohit Bhandari. Dilatation. If I have gone through the literature, and I would want each one of you to go through the literature and tell us any hard data which tells us, apart from one data where the stoma diameter of the Roux-en-Y gastric bypass had a bearing with the weight regain, is there any other data to prove or say otherwise? It seems from what I've read on the literature that if we can improve the energy spent on breathing, circulation, maintaining posture, and on digestion, we can have a great strategy for preventing weight regain. Well, obviously it can be done on a high protein diet because that takes a lot more energy to digest. But beware of this, that low carbohydrate diet is bad. It has been shown that the less carbohydrate you have, you will be having more metabolic adaptation. I leave it to you all and your nutritional team to decide what this means from the literature, but it is a it's definitely a path-breaking information that we are giving you. Increasing BMR, you cannot do it by running and swimming, but you can do by improving your fat-free mass. So each one of us, if we gain some amount of muscle, we will increase a BMR. So can our bariatric patients. If we can give them an anaerobic training, a weight training, a resistance training, they will have less weight regain, is my conjecture. Not a thing of the past anymore, or in the future anymore. It's there. A fecal-oral transplant, taking the feces from thinner subjects and feeding it to the obese subjects as a pill, is probably just on the horizon. It's going to come up because gut microbes are so important. They play such an important part in nutrient absorption and storage. Genetic mapping, we are working on it, and I can assure you in a year's time, we will come up with a model on genetic mapping to predict who are the weight regainers. We can do a simple test like CRP to predict which obesity is coming back. And the take-home message from all of this is just one. Again, setting up the stage for a debate on revision bariatric surgery, that if you know all of this, then we cannot just accept revision bariatric surgery without having more data on the physiological processes behind weight regain. Thank you very much.